tonight from beautiful Pueblo, Colorado. Thanks to everyone who's attending in person and thanks to everyone who's online. We're here to talk about MS with Dr. Andrew Wolf. I'm Kelsey Morrow, the Education Manager for the Rocky Mountain MS Center. I would like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb, Genentech, and Janssen Pharmaceuticals. This speaker series is just one piece of our education programming. We have a variety of formats available, including both in person and online. Most of our programs are available on demand through our YouTube channel, so if you just search for the MS Center, we've got lots of sessions of these conversations events, lots of past presentations, as well as a great webinar series. Our Fall Education Summit is the next event happening. It's on November 4th, coming right up. It will be both in person in Aurora as well as online on Zoom. And then before the end of the year, we have a lot of programming happening. We have another Conversations on MS with Dr. Corboy on November 30th. We have webinars on neuropsychology, MRIs, SSDI, and fatigue. So if any of those topics interest you, please make sure that you're on our email list or our Facebook group, or you can also sign up for notifications through Eventbrite. And now I'll introduce Dr. Andrew Wolf. Dr. Wolf is an MS specialist neurologist at the Rocky Mountain MS Center at University of Colorado. He studied at Arizona State University and then earned both an MS and MD from the University of Colorado, Denver. His research interests are focused on improving the treatment of patients with MS and other inflammatory diseases of the central nervous system. Current projects include evaluating treatment strategies in MS, the development of biomarkers for progressive disease, and better characterizing the safety of immunosuppressive therapies. He is also interested in patient neuroimmunology, including management of acute demyelinating disease and optimizing care transitions. We did have a lot of great questions tonight, so just wanted to let everyone know we'll get to as many of them as we can. And again, you can ask new questions as we go. Today's presentation is for informational purposes only. All decisions regarding MS treatment should be discussed with your neurologist. And with that, I'll turn it over to Dr. Wolf.
All right. Does that seem like that's working? Perfect. Yeah. So thank you everyone for having me. So it's very nice to be here in Pueblo. So I've not been down here in a couple of years. So who all's from Pueblo and who came in from elsewhere? Okay. Yeah. I think fortunately we do these sort of spread out, so hopefully people don't have to drive necessarily too far. So that's awesome. Yeah, so just a little more background on me. So I have been at the University of Colorado now for about 12 years. So I came up from Arizona to go to med school. Was really interested in neuroimmunology, so MS from the beginning. Actually, for those of you who know Dr. Alvarez and then Dr. Corboy, really my mentors for the last decade or so. So did all of my neurology residency and fellowship, and then started a faculty position this year. So really excited to be here for the first time. So we got a lot of really good questions, so we can just start running through some of those. So thank you for anyone who submitted them. So I'm going to go a little bit out of order here, because I think that starts to help us sort of set the stage for what we're talking about. So one of the, I think, really important questions that has sort of evolved over time is there's a question about how does primary progressive MS or progressive MS differ from relapsing MS? And probably a lot of you have been told, like, you have PPMS or primary progressive MS. A lot of you have been told you have relapsing MS. And some of you have sort of probably made a transition over time between relapsing MS to progressive MS. And I think I'll draw a little graph on here, but I think what we learned over time is those entities are not as separate as we used to think, and that it's pretty important for us both from a prognostic standpoint, but also for understanding how we can better optimize our treatment. So if we think about MS, as a disease, primarily we know that it's a longitudinal disease. So it's something that's happening over many years when we think about outcomes, right? So if we think about time in years, and I'm going to just move over here, what we're always worried about is neurological disability. So having problems from the MS, whether it's cognition, walking, pain, what have it. So, if we think about that on the y-axis, so just disability, we used to say that about 85% of patients presented with relapsing MS. So they would have a fairly quick onset of an event where something, like the right leg wasn't working. That would happen typically for most patients over a few days. Maybe after steroids, they would get better, maybe not completely back to normal. And then before we had good medications, maybe more of these events would happen over time. So that was sort of the thought of relapsing MS. And then after enough damage happened, because after every one of these episodes, there was a certain amount of damage to the brain or spinal cord, people would just sort of have this secondary progressive MS course where things just sort of slowly got worse over time. So that was most patients, but not all patients. And then some patients would just present more with PPMS, where they would just sort of have this slower worsening, but without relapses. So what we've learned over time, partially is we've had better drugs, which now drugs like Ocrevus, Ryumvi, Tysabri, these drugs that are really great at reducing relapses, is that even with reducing relapses, some of this slow worsening is happening for a lot of our patients, even from the get-go. So that's something we call progression independent of relapse activity, or PIRA, if you see it in like the scientific literature. But a lot of patients are just going to have some slow amount of worsening, even without having episodes where they're having relapses. So that's become an important focus for us as far as things that we should think about as far as finding new targets for medications. But probably those, progressive MS and relapsing MS are not as separate as we once thought that they were, despite our successes with really helping with this part of the curve here. So those are probably the biggest differences. There are therapies that are helpful for that progressive piece of MS. I typically tell my patients that if I was thinking about grading some of our new drugs as far as reducing relapse rates, I would give them an A or an A plus. As far as reducing progression, they're not as good, and not every drug even has any noticeable impact on that. So that's probably the biggest thing for us to think about in the future is not just progression for patients that have PPMS, but progression for patients sort of across the disease spectrum. So definitely some opportunities for us there. Does anyone have questions just to follow up on that piece of things? So we can sort of move on from that one to primary progressive MS update. So I think this one's mostly about therapies for primary progressive MS. So like we talked about, our drugs for progression are more limited compared to drugs for stopping relapses, for instance. So it's always important for us to think about, what other targets might we have, with that in mind. And there's just, of course, been a lot coming out about this. For those of you who have been to the education webinars, for instance, there's several new classes of medications and actually a whole bunch of clinical trials in one class of medications, which is what are called BTK inhibitors. So we would anticipate potentially having some results from some of those phase 3 trials, which are the definitive trials in the next probably 12 months or so. But so what BTK inhibitors are doing is if we think about our immune system, we all have an old part of the immune system that's not very advanced. So it's called the innate immune system. And that's, sort of the dumb but early response immune system. So if I get like a cut and it gets infected, I have which are just going to fight the infection, but they're not able to be programmed against a specific type of infection. And then we have the adaptive immune system, which is the immune system that learns from getting infections and learns from getting vaccines. So when I get my when I got my flu shot like last week, for instance, that helped program my adaptive immune system against the flu to better, fight off that virus should I get an infection. Um, because that immune system is smart, it can also have a tendency to get misprogrammed for reasons that we do not entirely understand. That tends to occur in MS, which we can talk about with one of the later questions. But those types of immune cells in the smart immune system, we have lymphocytes, so B lymphocytes and T lymphocytes, of which B lymphocytes tend to cause a lot of inflammation in MS. And those are drugs that have been targeted pretty successfully by drugs like Ocrevus, for instance. So Ocrevus, I would say, is very effective. It's not particularly elegant, where it's just going in and sort of blasting all your B cells and killing them, and then they can't go cause an inflammatory response in the brain. So BTK inhibitor is a little bit different. So they're going in and actually inhibiting a pathway in the B cell that allows it to become extra inflammatory and sort of slowing that process down. So the thought is that those may work a little bit better for progressive MS because they are able to some degree to penetrate better into the brain and spinal cord and potentially reduce inflammation that right now is sort of hidden in your brain and spinal cord with the MS. So drugs like Ocrevus, other antibody drugs, Tysabri, those are too big to get into the brain, and they cannot necessarily impact that inflammation very well, although some of them may have a limited capacity to do that. And that's a problem with a lot of diseases in the nervous system, is that bypassing this special barrier between the blood and the brain or the spinal cord can be difficult, because our brain is trying to keep external things out so that it doesn't get infected all the time. So these drugs have promise. We always have to have the big studies to see sort of how well they actually work. I'd be surprised if they didn't work at all, but we won't know for sure. They're better than any current therapies until those studies are completed. I think the other big things which will come up in a couple of these other questions are there non-immune system pathways that can be targeted to help with things like disability from primary progressive MS, for instance? And the answer is probably, but we have not quite, necessarily figured out exactly, what works and what doesn't. There's a number of studies that we can talk about that are attempting to do that. But that's been one of the more, like we mentioned earlier, like this progression piece has been one of the more challenging, pathways for us to attack compared to relapses, where we now have, depending on what you count, about 20 drugs that have been effective for reducing relapse rates in MS. Just keep track of where I'm at here. Yeah, absolutely. Yeah. Um, yeah, so so we got a question asking about BTK inhibitors specifically for preventing symptoms, perhaps in patients at risk. That gets a little complicated, but I think is an extremely interesting question for us. So, we know that for the most part, when the nervous system gets damaged, the cat's out of the bag. Like, we don't have any way to repair the nervous system very well at the moment. So there's definitely been interest, and this extends beyond MS to other sorts of neurological diseases, of trying to detect people who are at risk or in the very earliest stages of the disease, so we can put them on treatment really early. So probably the best example of that on the MS spectrum, just to take the question a little bit further, is an entity called radiologically isolated syndrome, or RIS. So fancy words. But RIS essentially means people that have lesions on their brain that look like MS, but they have not had symptoms that are typical for MS. And that may just be luck based on where those lesions happen in the brain. It may be that they have more reserve for whatever reason, more brain volume, etc. But it's not common. But we certainly, I probably see a couple patients a month that have this, that get an MRI because they have headaches or got in a car crash or something else that's not an MS symptom, and their brain looks exactly like an MS patient. So historically, we've not really known what to do with those patients. So we're sort of like, are you going to get MS or not? I'm not so sure. Do the lesions keep happening if we don't treat you? Not so sure. And again, it's sometimes hard to study these populations because we don't see all that many patients that are in that situation. But within the last year, we've actually had two studies that took those groups of patients and actually put them not on BTK inhibitors, but on other medications, and said, hey, if you don't have any symptoms, maybe we got lucky that we found that you might, have MS on the MRI. Let's put you on medication and see if you ever develop symptoms or not, so you convert to having MS, for instance. So they used two other oral medications. Tecfidera, which is one of the oral meds that's been out since about 2012, and then Aubagio, which is another oral medication that's been out, I think just over 10 years now. Put people with RIS on those medications and then followed them over time and saw that a markedly lower amount of them developed this actual clinical MS. So I don't know exactly right now as far as guidelines or practices, would we use BTK inhibitors in that situation or not? My personal practice is that and I think a lot of us at our center, we tend to be pretty aggressive with treatment, right? So I tend to use a lot of the higher efficacy therapies. BTK inhibitors may fall into that category, they may not, but we've gotten more aggressive over time at trying to do things as early as possible. Because most therapies, at least in the short term, are actually pretty well tolerated for patients. What we don't want is to miss that opportunity to intervene. Because the risk of having bad relapses or really rapid progression, for instance, tends to be worse at the start of the disease. Does that answer your question? Okay. Yeah, so let me erase this real quick because I think the next question we had was about the B cell therapies. So that would be helpful for us just to write those out. That would be. Okay. So we had a question, how do we differentiate between B cell treatments? And what are our thoughts on infusion versus injectable therapies? Oh, thanks. So we'll write those out real quick because we have, the more traditional B cell therapies. We have BTK inhibitors, which are not quite available yet. And then we have maybe in the future some other, what almost sounds like science fiction B cell therapies that we can talk a little bit about. So right now we have the infusions. We have an injection, which is sorry, I'll try not to be confusing with brand names versus generic. Okay. So part of the question was infusion versus injection. So We have 3 infusible B cell therapies. All of these B cell therapies are going into your blood and partially into your lymph nodes where the immune system lives, partially into the brain and killing B cells, which is that one of those smart immune cells that's causing inflammation in MS. These are all, so Ocrevus, Briumvi, rituximab, all every 6 months, essentially on a maintenance process. Rituximab is the oldest of these. So rituximab was actually invented for cancer treatment. So those same B cells that are misbehaving in MS or like in things like lymphomas are just multiplying out of control. So the oncologist invented this drug. It goes in and binds to a little flag on the B cell and kills them. And then essentially we stole their ideas for MS to kill those same cells, because if we kill them, then they can't do bad stuff in your brain and spinal cord. But these are all CD20s, so they're acting on B cells. So B cells have a little flag called CD20. Drugs go in, bind to that, and then kill the cell. So reasonably straightforward. But rituximab's been out since 1997. It was never underwent a phase 3 trial for MS. So some insurers won't pay for it. But if you were in Sweden, for instance, they use a lot of rituximab because it's cheap. If you're a Kaiser patient, they use a lot. We love rituximab. It's great. We love rituximab, which is the brand new one, and Ocrevus too. Right now there's not a lot to suggest clinically that like any of these are more effective than the other ones. Some have different infusion times and that sort of thing, which may be a benefit. If I told you you could be in and out of the infusion center, in an hour and a half versus 6 hours, you'd probably be pretty happy about that, I think. So these also at the moment don't tend to have compelling differences as far as safety. So infections, infusion reactions tend to be the major issues that people can run into. And then we have essentially an injection version, which is Kesimpta. So just for reference, so rituximab 1997, used a lot for MS in some places since about 2008. Briumvi this year, Ocrevus 2017, Kesimpta 2020. So partially like when I'm deciding between these with patients, like Ocrevus has more data for progressive disease, but I imagine all of these probably work pretty similar for progressive disease because they're very similar medications. So typically we are, insurance kind of puts this one on or off the table. We are just working on getting ublituximab or Briumvi available. So historically, we've sort of made decisions more on the convenience aspect of the patient. If it's easier for you to do an injection at home, wonderful. And you can do Kesimpta. It takes probably 15 minutes of your time, per month. So that is very convenient. If you hate needles, or you like just going in every 6 months, like I have a lot of patients that travel or do other things where carrying around a refrigerated like injection pen is not going to be a great idea, then Ocrevus works. So I doubt that we'll probably ever have like very clear head-to-head data between these drugs, but they're all really nice options for us. So we're happy to have this. Yeah. Yeah. So great question. So so we had a question about antibodies being formed to the drugs that may impact efficacy. So we know quite a bit. We think about the antibody drugs. So all of these things are foreign substances that are put into your body. It sounds perhaps a little strange, but like most of them are manufactured in part from like mouse cells and that sort of thing. So like these antibodies have parts in them that to your body look like mouse, for instance. So your body creates an immune response to it, including antibodies that can bind to the drug and theoretically make it not work as well. So we know pretty well for natalizumab, Tysabri, so a different drug that's not in this class, that if you're exposed to Tysabri, or even if you're not, you can have antibodies against it that make it not work as well. The data on that for these drugs right now is pretty limited. So we know that a sizable percentage of patients can make antibodies against rituximab, but it's difficult to know sort of which ones of those are neutralizing, where they stop it working, and which ones don't, if it has any clear like clinical impact. For the others, I'm not aware of any like much data at all at this point for those things. So hard to say, but I imagine that it is certainly possible, and something that we may think about in the future for sure. Yeah. So as far as yeah, Preambi, yes. So approved. So right now, data for relapsing MS, really for all of these except in phase 3 studies, except for overdose. I have personally some reasons that I think Briumvi may be more helpful for progressive MS, but we don't have definitive clinical data. Part of that is it's a little bit more potent at killing B cells. So if we think about like our brain, like let's say some of the important B cells that are driving inflammation are not in the blood, but are just in the brain, for instance. You have that blood-brain barrier. If only a very limited amount of drug is crossing, into the brain, having a more potent drug that kills cells, sorry, at a lower concentration of the drug may be helpful. But that's not been proven yet. But it potentially, that could be helpful for us because that is the most potent at killing cells, at least in lab models compared to these other drugs. Other B cell therapies, so BTK inhibitors, we talked about a little bit. And then more of the sort of science fiction thing, again, like we love to steal ideas from the cancer doctors. So, one of the revolutions in hematology, so in blood cancers, has actually been reprogramming a patient's immune system to kill cancer cells. So especially in blood cancers, let's say I had lymphoma, for instance, we could actually take out parts of my immune system, reprogram them in the lab to kill the cancer cells. So like my T cells, for instance, that other smart part of the immune system can then go in and kill my own cancer cells, which is extraordinarily effective. So, the thought process from that's called CAR T, but the thought process from that for the MS standpoint is that we could take cells for these drugs, but we could also add in regulatory immune cells. So the immune system is quite complicated. We have things called Tregs, which are regulatory T cells. Those basically signal to help ramp down inflammatory processes. So let's say we could program pathways to reduce inflammation just by giving me like an infusion of T cells. There will be trials for that assuredly for MS, certainly in the next couple of years. We've seen that just in the last year for other autoimmune diseases and neurology, for instance. For myasthenia gravis, which is a disease, there was a study published earlier this year that's essentially doing that sort of thing. So, those are all on the radar as far as things that may be, even more helpful therapies that work on B cells. All right, and then a couple of these are tied together, but since we're on a B cell list here, we'll kind of pivot a little bit to research on Epstein-Barr virus. So Epstein-Barr virus is a very common infection. So most of you have probably heard about Epstein-Barr virus because it causes mononucleosis. So even if you've never had mono that you've noticed clinically, about 95% of us have had mono probably by the age, or had Epstein-Barr virus infection probably by the time we're about 25 or a little bit later. There's been a lot of interest in Epstein-Barr virus over time because we know that Epstein-Barr virus infects B cells. So one of the thoughts has been, does something happen with Epstein-Barr virus that changes how those B cells work? that can then trigger MS to happen. Um, that has over time. Yes, so we do have Epstein-Barr virus vaccines actually, and so historically that development happened because we know very clearly that Epstein-Barr virus infection, when it infects B cells, can um, trigger specific cancers and other things. So like different sorts of lymphomas, as well as like gastric cancers. So there's been a lot of work more on that avenue and making vaccines that we know are pretty effective. So the issue that we have, I think you're probably correct. So if we walk through, probably the most informative study for us was actually looking at a military population. So when people are enrolled through the Department of Defense, they actually have to have blood draws. I think it's every 6 months or every year. Starting at age 18 if they're enlisted at that age, right? So we can sort of track over time who gets Epstein-Barr virus. Because you get the virus, you make antibodies against the virus, and we see those in the blood typically, forever. So when we looked at that population, not me, but as a field, we looked at that population. Essentially, there was only one patient that got MS diagnosed without having Epstein-Barr virus positivity if we were to track them over time. So it may not be sufficient. So just having an infection of Epstein-Barr may not be enough to cause MS. But it may in part be necessary as part of a trigger on a susceptible background of whatever genetic factors or vitamin D deficiency or bad luck or whatever else causes it. So I think we would love to, of course, then exploit that to prevent MS from happening. I think even though we have vaccines, I think for Epstein-Barr, I think the challenge is the numbers. It's pretty easy to run a vaccine study for COVID because if we didn't give anyone a vaccine, like they would all get COVID, right? So we know without an Epstein-Barr virus vaccine, that like 95% of us get the infection. But if we look at data for the whole population of the U.S., for instance, only like 1 in 300 of us would get MS. So the numbers for doing that study logistically get very challenging, where it's like tens of thousands of patients. And I'm fully in support of essentially every vaccine that's ever been approved. But the other challenge, of course, is that 40% of people have been infected with Epstein-Barr virus by the time they're age 13. So we start talking about having to give these vaccines very early with whatever potential side effects they might have, with a relatively small chance, like 1 in 300 or whatever, of getting MS. So it's just a challenge on those levels, and that certainly would be a definitive way to sort of prove that this link was there. So it's a very interesting idea to think about from that standpoint. Probably what we need to figure out is, can we figure out a group of patients that's at even higher risk for developing MS, whether that's genetic or otherwise, that may predispose them to Epstein-Barr virus infection just being that final step. And then you can imagine if we had a group that we knew was super high risk, we may be able to accomplish that study with much smaller numbers. Right now we're not there. That's for those of you who have heard about, DREAMS and RISE, or studies looking at biomarkers or sort of younger family members of patients with MS, trying to identify, for instance, are there specific things that we can pick out from a prognosis standpoint to say who may develop MS and who may not. Just right now, genetics for MS susceptibility, or just we have not ever still figured out a very strong predisposition, so it makes it harder to do that sort of stuff. Yeah, but really nice question. Yeah. Uh, yeah. Yeah, so the question was about Epstein-Barr virus, like prevention. Um, the answer to that, so people in the US actually get Epstein-Barr virus infection later than a lot of the world. Um, Part of that is just hygiene practices. So if you're in less developed countries, frequently people are getting infected like younger ages. Like, is that protective somehow? I'm not sure. Um, as far as I know, I'm not aware of like severity as far as a modifiable thing, like the severity of like infection being an issue. If you do get mono, as opposed to like an asymptomatic Epstein-Barr virus infection, that does tend to have an increased risk of MS. And that probably just indicates that something about your immune system is different, that then may trigger some sort of downstream process. But right now, there's not a clear way to intervene on that. I'll answer a quick one. So, do we have any information on Copaxone intramuscular? When might that be available? So, Copaxone is a glutamer acetate, one of the older injectable therapies for MS. So, like most things over time, there's been different formulations that are made of medications. So one of the new things that has come out for Copaxone is actually a monthly injection as far as going through clinical studies. So that is certainly easier than doing that, like multiple times per week, for instance. I believe the new drug application for that. So when drugs are getting approved, they have to go through this FDA process. That was submitted in August of this year. So I think by usually it takes about 6 months. I think March 2024 was potentially when that would be due for a decision by the FDA. I imagine that it would be approved, and then it may take some time to get on the market. Probably that's not a game changer from like an efficacy standpoint. I think that's probably pretty similar to the Copaxone products that we have now, but it may be much more convenient. Where I see that potentially fitting in is for some of our patients who've been really stable, and that maybe we would keep them on a little bit of a drug, but not want them on a high-powered drug like these drugs. That the monthly would be attractive because it would be much better for the patients to not have to inject themselves all the time. But I don't see a huge difference in that from like, we're not breaking barriers with a different way to treat MS. It just is a good question. Since we were talking about vaccines, we got one that said, I'm over 65. I plan on getting flu vaccine and COVID vaccine. Do I also need the RSV vaccine? So current guidance would be over age 60 for RSV vaccine. There's nothing to suggest that it would be unsafe in MS patients. So I generally would recommend getting the RSV vaccine. All right, so a couple other questions. So is either of the two approved RSV vaccines, um, Abrevso or Arexvy, preferable? As far as I know, I don't have any preference about those. Um, Both RSV vaccines had a higher incidence of Guillain-Barré syndrome than other vaccines. Is it a concern for MS patients? Um, I've not seen a specific study where MS patients were included as far as RSV vaccination trials, for instance, and broken out. Typically for these inactivated or protein subunit vaccines, we don't really get worried about the higher rate of immunological complications in MS patients. Where we get worried is any sort of live vaccination if you're immunosuppressed, because if we give you a weakened live virus, it could theoretically make you sick. So I don't have any specific concerns about that. Then any data on pseudo exacerbations. So just to define a pseudo exacerbation, so pseudo exacerbation would be feeling worse as far as symptoms, typically from like being sick or not sleeping or something that is not the MS getting worse. So certainly if I, gave a lot of people COVID vaccines that have MS, just like when I got my COVID vaccine, I felt terrible. So, having your old MS symptoms get a little bit worse for a short time period would be a pseudo exacerbation if it was happening in that setting. So I've not seen data on that. I suspect that it could certainly cause pseudo exacerbation symptoms, but that should be short-lived and sort of self-limited. Yeah.
Is the you recommend having a shot as a
So there's no safety data that it would be concerning to do them at the same time. Some people, oh, sorry, question was about flu and COVID vaccine timing. Can they be given at the same time or not? So I'm not aware of any safety issues with that. Some people get sensitive, especially to the COVID vaccine. So if you've had a reaction to that where you just felt crummy, it may make sense to space it out a little. But it should be safe to get. Ideally, yes. I fall probably a little bit in a different camp than some of my colleagues as far as that's concerned. If you're on one of the B cell therapies like these guys, and part of that is because we tend to see from the data that we probably have to wait like 9 months after the infusion for it, for that B cell response to start to recover. So I'm not sure how much it actually matters. We do know at any time that we give it to you, the other part of the immune system, the T cell response, is going to work. So I typically say, like, if it's easier for you to get it a month before, then great. If that is difficult, then I would just say just get it. It would be most important. Yeah. 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 Um, so question is about secondary progressive MS and optimal medications. Um, so, this is where we run into thinking about, how much of a difference is there between primary progressive MS and secondary progressive MS as far as mechanisms. And I'm not really convinced that there is a huge difference there. So, I like to just say progressive MS in general. And, some of the secondary progression piece, I think, in part comes out with other issues. So, aging, there's other medical comorbidities and that sort of thing. Siponimod or Mayzent, which you mentioned, that's is certainly a reasonable drug to use in that setting. For most of our progressive patients, we would tend to use more of the B cell therapies just because of the specific data around like the cleaner sort of progression model in primary progressive MS. So those are there. There are trials of BTK inhibitors actively. So there's one that's a little bit unusual to run a trial just for what's called inactive secondary progressive MS or having secondary progressive MS, but without relapses. There is one study that's looking at that. But there's several studies looking at these BTK inhibitors again in progressive MS. So that, would be potentially on the radar in the future. Um, the other piece of things too is if you're having relapses, even if you fall into what's classically been called that SPMS camp, any of the drugs that reduce relapses may be helpful with that piece. But again, like, what we're not as good at treating is if you're slowly getting worse, most of our drugs do not have an enormous impact on that process. But again, these would be, in my opinion, the ones that have the best evidence as far as changes in brain volume and other metrics that we look at, in addition to like the clinical exam. The mention of Mayzent or Siponimod, I think, brings up an interesting point just with having COVID. So that those drug classes work, or that drug class works a little bit differently than the B cells. So how Mayzent, which is Siponimod, Gilenya, which is Fingolimod, Ozanimod, which is Zeposia. So there's a lot of drugs in this class. How those work is actually by taking lymphocytes and then blocking them from getting out of the lymph node, which is where they typically hang out. So that tends to be pretty challenging from a vaccination standpoint. So like if I'm killing all your B cells, that is sort of making half of the vaccine response not work. But the part that's driven by T cells is actually maybe overactive for our patients on Ocrevus, for instance. If we're keeping all the lymph nodes or all the cells in the lymph nodes and stopping them from getting out into the blood, like with a vaccine, it makes it much harder to have an appropriate vaccine response. So it's just something to think about with those medications in particular. But we use a fair amount of those for different reasons. We tend to use a little bit less Siponimod or Mayzent just because historically there's some genetic testing involved to based on how your body processes the drug. So that's sometimes been difficult to get. So we tend to use a little bit more of Zeposia these days, but good medications overall. Yeah, absolutely. So, got it. So I think we'll pivot a little bit to this one because it ties in with SPMS, which says, what can I do to preserve my brain as I get older with SPMS? So I think, there's different things that we think about from that regard. So, the obvious one is if we have a drug that impacts SPMS directly, that we should have, someone on that medication, assuming they tolerate it. The things that I think are often not talked about enough in clinic visits are all the other things that impact your brain health. So we put that in perspective. So, our brain is its maximum volume, so maximum number of connections and cells when we're about age 25 to age 30. Every year after that, the brain gets smaller. That doesn't necessarily a bad thing right away. Like some of it is that it's sort of rewiring itself a little bit. But we all lose brain volume over time, and at some point that starts to show up with symptoms, whether that's age-related memory loss or just cognitive fatigue, or things like actual memory and thinking problems like dementias and that sort of stuff. So everything that we try to do, from a philosophical standpoint in treating MS, like in my clinic, is how do we, slow that process down as much as we can, because we want to keep our brains healthy as long as we can, whether it's just from the MS or otherwise. So the MS part, like I said, fairly straightforward, but we know about all the other things that impact brain health. So, probably the far and away the biggest one that most of us struggle with over time is vascular risk factors. So, for smoking, smoking is very harmful. But then the sort of the mundane stuff that your PCP is always ordering on labs. So cholesterol, blood sugars, blood pressure, all those sort of things really need to be optimally managed, because we can look at the literature from Alzheimer's disease, for instance. So very different disease from MS. but all of those things are major impacts on how, the risk of that and how people do over time, right? And we also are able to manage all of those things actually quite well. So if you get diagnosed with high blood pressure and you treat the high blood pressure, then that risk is markedly reduced. If we treat the cholesterol, which we're actually phenomenally successful at doing, then that risk is reduced. So those are very important things for us to think about. There's a few that are less obvious. So, one thing I tend to do a lot of in clinic is talk to patients about sleep. Over time, we've learned about untreated or undetected sleep apnea being also a major vascular risk factor. So that tends to, be another thing that's also very modifiable. Because if I diagnose someone with sleep apnea and put them on a CPAP or some other intervention, then that gets better and we don't have the worsening that is accompanying that problem. So those are big ones. The other one is exercise. So we know that exercise from a variety of models is beneficial for brain volume and also for actually helping the brain sort of forge new connections and rewiring. So, if you actually can do studies like, take a mouse, make a mouse run on a little mouse treadmill, which sounds weird, but it's something that they do. You can have a little actual little catheter into the brain and measure different chemicals like as you make the mouse exercise. And one that tends to be elevated associated with exercise is a chemical called BDNF, which is brain-derived neurotrophic factor. So that's actually a chemical that helps our brain forge new synapses and connections. So the exercise is good from the heart standpoint, the blood pressure standpoint, but it also may directly impact your brain's ability to sort of withstand damage just from aging or from MS, for instance. So I think those are all big ones. The other things we would think about from that standpoint, staying cognitively engaged as best that people can is also helpful. And then trying to, if there's some sort of comorbid like mood disorder, untreated anxiety, depression, we know those are also linked with those sorts of concerns with cognition and things over time. So it's a multifaceted approach. An MS drug alone is not going to necessarily fix the problem, but I think that's also where we see some of these newer therapies that reduce that brain volume rate of patients with MS closer to normal controls. So a lot of different things to sort of work on. Yeah. Excellent question. So that is something that our group has been very interested in. So the question is about discontinuing therapies with age. So Dr. Corboy, who some of you probably know, so he actually just had completed and published a multi-center clinical trial called DISCO MS or DISCOMS. So that was essentially taking patients who were stable, who were over the age of 55, and taking half of them and stopping their medication and taking half of them and continuing their medication and seeing how they did. So the background on that is that we expect that MS is less inflammatory, or you have less risk for relapses, or less risk for relapses as you're older or as you're further from disease onset. So we think about, the severity of MS as far as the inflammation, it starts high and over time it sort of drops off. That's part of a fairly natural process called immunosenescence. So for all of us, our immune systems get weaker as we get older, and that then ties into autoimmune diseases. So, historically, most MS studies have looked at patients who were 18 to 45 or 18 to 55. So not a lot of data about treating older patients. And the thought was if you look at if they're having relapses, older patients do not have as many relapses, especially if they've been stable for a really long time. So we also know that complications from treatments increase with age. So, as you get more prone to infections, for instance, having you on an immunosuppressive therapy like these therapies is more dangerous. So there's sort of a different, balance there, but we want to, see how much bang we're getting for our buck of having that risk, right? So those were sort of the reasons behind the study. So in DISCO, essentially the rates of having relapses for those patients in those two groups were very low. They were a little bit different than the medications that a lot of our patients are on these days. So there's a lot of injectable therapies like interferons, Copaxone, that sort of thing. And I think the way that Dr. Corboy and some of the press releases have talked about the results is sort of my interpretation. Where his quote was something akin to like, we can interpret this how we wish to, that if if it otherwise would make sense to consider stopping a therapy out of convenience, cost, safety, then it's a reasonable thing to do. But if a patient's tolerating it and they want to continue it, then it's reasonable to continue it. But I think that opens up the option when historically most of us were just always afraid, no matter what, to ever take someone off of the drug because we were afraid something bad was going to happen. And certainly the risk of disease worsening in that group is quite low. That is not the case for younger patients, right? So there's been studies similar. So we had the International ECTRIMS meeting for MS just a couple of weeks ago. So studies of taking younger patients off drug, for instance. Right now that doesn't seem like a good idea. If you're, at least with the current therapies, like, if you're 40, you had a relapse 5 years ago, you've been doing great on Ocrevus, like I would be very worried about stopping therapy in that patient. But 65, no relapse in 20 years, clinically stable, MRIs that have been stable. I think we're probably in a pretty good spot at that point. But if you're tolerating the drug, then it may not be an issue. Yes. Yeah. Yeah. So I get more worried about the questions about later age of diagnosis. So I do get more worried about later age patients. And part of that is just that watching that natural history of relapses over time. So like, we've not had, some of you in the room have been around long enough, I think, but, we haven't had MS treatments like in the grand scheme of things for all that long. So we're like the 30th anniversary of beta seron this year. So for patients that get diagnosed later, like, we used to have a bunch of natural history studies where we would follow people and they had no access to drug. So typically about 15 years is where we really see that relapse rate sort of decreasing. So let's say you were 65, but you were diagnosed at 55, like, I would certainly be more concerned about stopping therapy, in that context, even if someone was stable. There was a question on here too about stopping Tysabri, so natalizumab. So I think the question was, I've been on Tysabri for 15 years. I'm age 60, my neurologist unfortunately passed away this year. My new neurologist is considering switching to Mavenclad, which is cladribine, moving forward. Yeah, so that gets to like a very specific discontinuation question. So for a lot of our therapies, including these therapies, Copaxone, interferons, Tecfidera, those classes of medications, we are not really worried about making the MS worse by stopping drug. It may go back to where it was, but the relapse rate should not typically increase if we stop drug. The problem with Tysabri, and I'm not sure with this specific question if the reasoning was just age, like has come up, or if the JC virus status changed or something like that. But the issue with Tysabri, as well as the issue with some of the S1P drugs, so Gilenya, which is fingolimod, potentially ozanimod, Mayzent, siponimod, is rebound disease. So one thing that we know best from Tysabri is that if we have you on Tysabri and we stop Tysabri and it transition to a different medication, especially a high efficacy medication, there's risk for having the MS get worse in the short term. So I don't have a problem with stopping Tysabri really for whatever reason. But my typical practice, not that cladribine's bad, but when we look at retrospective studies, we see that patients that transition to cladribine tend to have more relapses after stopping Tysabri than if they switch to a drug like Ocrevus, for instance, even for the short term. And we see that with Gilenya, and we also see that with Tysabri. So I don't think it's a bad option. It's probably not exactly what I would do. Even if we're not going to keep someone on drug long term, I will frequently, for my older patients that just want to be off drug but are on Tysabri, I will very frequently just give them Ocrevus like 1 or 2 times and then just be done. Because this one can just wash out and doesn't cause any problems. Yeah.
I understand those very small studies that patients will take it off without taking the symptoms. And basically quit as if as what they've been practicing. Talk about that.
Yeah. So let's have a little bit of background on 2 other drugs that we haven't talked a lot about. There's 2 drugs that are specifically marketed as what we call immune reconstitution drugs. So they're basically like going in and disrupting the immune system. And then, the thought is that after that treatment, the immune system sort of like regenerates itself, but it's not, then going to have the MS related inflammation with it. Cladribine, which is Mavenclad, is one drug that works that way, where it's not typically a lifelong treatment, but it comes in a treatment course over a couple of years. And the other one is alemtuzumab, which is Lemtrada, which is not used as frequently these days, mostly because of side effects. So those drugs historically have been marketed as like a one and done, like you get the treatment course and then you're sort of good to go. Like hopefully the MS is shut off. They are fairly effective, but some patients do not have great durability, let alone the side effects. Where like with cladribine, if we follow those patients out several years after the treatment course, like a minority but a sizable percentage of them start to have relapses again, for instance. So cladribine, not a bad drug. I don't use a tremendous amount of it, but it is sort of like falls a little bit, probably in my opinion, beneath the efficacy of these drugs. So more recently, getting to your point, the B cell therapies have been thought of. They're certainly killing a lot of the immune system. Does that do enough to sort of reconstitute the immune system or not? So the answer is we're not sure. We certainly have data, especially driven by COVID, that if we have you on some of these drugs for a while, then you just stop coming in to get your infusion, because that happened with a lot of patients during COVID where they just stopped coming. So in France, for instance, there's some centers that have like 100 patients that they followed that were basically stable on like Ocrevus and then didn't go get infusion for 2 years. They tended to do fine. So does that mean that's going to be a long-lasting thing or not? I don't know. There is actually a clinical trial for newly diagnosed patients, so with disease onset within 12 months, that is pretty aggressive from that standpoint. So it's basically taking a couple different groups of patients, if I remember correctly, and putting them on Ocrevus, and they're either going to have them on Ocrevus for a year, for 24 months, or I believe the study is 48 months, and to have the third group just get Ocrevus that whole time, and then look to see sort of how they do. Because I think we'd be very interested, for instance, if we could just give you Ocrevus or any of these drugs, Kesimpta, for a year and then just stop it. Maybe that would be great. That would certainly reduce the side effects and the cost of the drug. So we're just not sure yet. Yeah. I think if you had to make a prediction, like I think it's very likely that if we were to think 5 years into the future, that at least for a lot of our patients, we will not be giving these drugs as frequently as we do right now, especially for relapsing disease. Progression is sort of, we're not so sure about progression, but for relapses, like what's called extended interval dosing, so giving like Ocrevus once a year or rituximab once a year, for instance, it tends to be seem to be very effective at reducing relapses, where that is probably not any better than doing it twice a year. So there are a few clinical trials actually looking at that are being done in Europe, where they use a lot of these drugs as well. Yeah, and then just because it's sort of a pivot point, we had a question about stem cell transplant. So sort of the ultimate immune reconstitution therapy. So we have cladribine being one, like ultimate way to sort of reset the immune system is to do stem cell transplant. So stem cell transplant sometimes gets a little bit confusing. So, what we're really doing with stem cell transplant is not so much that the stem cells are like directly treating the MS with this sort of transplant, but that we're basically destroying the entire immune system with chemotherapy. And then we're giving the stem cells back because the stem cells can regenerate the immune system. That is sort of, fundamentally has been done obviously a lot for blood cancers where we try to kill every blood cell essentially, and then allow them to regenerate from like, clean non-cancerous stem cells. So stem cell transplant for relapsing MS tends to be extremely effective, depending on the protocol. So, we kill off the entire immune system, and then regenerate it, and it doesn't have whatever factors led to MS forming. Then people tend to have very low relapse rates. All of that at the moment has primarily been driven by retrospective data and mostly by small studies at specific centers, as opposed to the ideal situation of taking our best available therapy, so like one of these, putting half the patients on that, half of them on the stem cell transplant, and see who does better. There is a study doing that, which is called Beat MS, that if anyone's interested in that, we are actually a center that is part of that trial. So where people can, go on Ocrevus or go on a stem cell transplant. Right now I'm a little bit dubious as to is the stem cell transplant significantly better to justify the side effects of it. So stem cell transplant is certainly much more dangerous in the short term than being on Ocrevus because we're blasting the entire immune system. Rate of infections and other complications is pretty high. The counter argument to that is that that risk is very much front-loaded. So if I get a stem cell transplant, I'm at risk, while my immune system is still growing back for X amount of months, but then I'm fine and I basically don't have MS anymore, then that might be worth it. Compared to, Ocrevus, which, right now, if I'm diagnosing someone at age 30, I don't know when I'm going to stop it, but it's certainly going to be, like at least based on current evidence, like probably 25 years if they're on drug. That whole time there's going to be some risk of having infections and other things. So it's a little bit unclear, sort of, what would be best from that standpoint. I think if things look the same, if we finish this Beat MS study, they look like they're both about the same in efficacy, then that very much becomes a decision with what the patient's preferences are. A careful discussion. If the patient's like, hey, I want to just like do this and take a bigger risk and then be done, then perfect. And if they're like, hey, that sounds really scary to me, I'd rather just, be on Ocrevus, maybe have a smaller risk, but a longer term of risk, then that's also reasonable. Stem cells a little bit more too from that standpoint, more complicated as far as things like family planning, for instance. So, we blast, especially reproductive age women if they're interested in having children, for instance. We just blast them with chemotherapy, like that can certainly damage the reproductive health in a way that's not really recoverable. So, just another patient-specific factor, because for some people that's not important thing to think about. So we just have to have all that stuff on our radar. The specific question was about SPMS or progressive MS. So there's not particularly compelling data about stem cell transplantation in that context for progressive MS at the moment. You have to be very, very careful about sort of where to do those sorts of things. So like if you have relapsing MS that's really severe, then absolutely you should try to get enrolled into the MS because that has incredible oversight of expertise. You're not having to pay like out of pocket for it. The question specifically was about a clinic in Mexico called Clinica Ruiz, which as far as I know is a professional clinic that does the right thing. But the last patient I had that went there had to pay $120,000 cash for their stem cell transplant. So it's very challenging when we could theoretically, do the same thing in the U.S., like through a clinical trial funded by the NIH and your insurance. And then the data is just not really there for progressive MS. So if that's the aim, is treating progressive as opposed to relapsing MS, I just can't say that I'm sure that it would help. I didn't have a specific question about it, but I do want to mention just because we're on the topic of stem cells. So stem cell transplant being a different thing than like regenerative treatments, just because there were a few questions about, how may things get better over time with MS. So stem cell treatments have sort of evolved over time. So stem cell treatments are different from the standpoint that these are things like, getting stem cell injections that are supposed to go like fix your nervous system. Right now, we don't have anything that we know works. There was recently what's called a phase 1 study, just looking at safety and what we call exploratory markers. So looking for, evidence of things that are positive for nerve health in the spinal fluid after giving a stem cell product. And the safety profile looked okay. We don't know that this sort of drug works, but you could definitely, go somewhere, Russia, Mexico, other places, and get these sorts of treatments done to you. Again, last patient I had that did that paid $18,000 cash. The safety of those is incredibly dubious. Like I would be very worried about someone doing that, one, because I have no evidence that it works, and two, because I've seen some very bad things, including patients that have died from infections from getting those sorts of treatments. Ideally, we will have a fancy stem cell product in the future. It's just not ready for prime time, unfortunately. The other repair pieces, other repair things that we think about are things to like fix myelin, for instance. So, if we damage the myelin in the nervous system, all these remyelination therapies have been thought of as like the holy grail of like fixing damage from MS. We have tried a lot of them. None of them so far have worked. Biotin, the most recent one that did not work. Currently, alpha lipoic acid, which is a supplement, is being studied, and then a drug called clemistine that acts on some histamine pathways that may help with repairing the nervous system. So those, may be beneficial. They may not be. It's very early to say. I think the other one sort of in that group that comes up a little bit just related to progressive MS. So in my opinion, probably the most promising sort of like add-on therapy for progressive MS is the simvastatin study, which is being done right now and should have results within probably the next 18 months, which is in the UK. So that is putting patients on high doses of simvastatin, which is a cholesterol medication, but has other effects. So when we look at some of the earlier studies of simvastatin, looking at progression, it actually looked pretty promising at slowing progression down. And it did so in a way that was, actually even independent of the cholesterol levels, right? Because you could think about, if I have really bad untreated cholesterol, that's also impacting my brain health. If I just treat the cholesterol, maybe that's what's going on if I'm on a statin. But it tends to look like there's some other effects of statins, which we know from things like stroke, for instance, that they act on other pathways, including potentially on some of the inflammation processes that can impact myelin. So that's probably the most promising one to me, and one that we may see some results from in the near future. And we also know that statins are safe drugs, because I don't know how many people are in this room are probably on a statin, but it's definitely several. And statins have been out for a long time, not any sort of like scary side effects from them, maybe. So yeah, so that's the one. pathways as well. Metformin also may be helpful. P1 drugs that can be extraordinarily effective with weight loss, blood sugar control, cardiovascular outcomes. So I anticipate we probably will see some studies as well from those as add-on medications for progressive MS. But right now, too early to have any definitive answers as far as that goes. But again, it's sort of focusing on we think we've made a lot of success with reducing relapse rates. So now we got to attack every other pathway that may be causing damage in MS, right? And do our best to slow everything down or prevent things from getting worse. And that's where we have to be creative, repurposing other medications and looking at repair and all of these aspects to try to do that. So that's one. So is the microbiome system still a subject of interest, and what are researchers exploring in the microbiome world? So absolutely still a topic of interest. So the microbiome, essentially all of the bacteria and other organisms that sort of live along with us in our body. So, it sounds crazy, but if we think about just our gut, our gut has as many cells of bacteria, for instance, floating around as we have cells in our own body. And all of those bacteria are doing different things as far as signaling and other parts that help to regulate and guide the immune system. So with a lot of diseases, we have been able to identify specific pieces of the microbiome that may cause certain immune reactions. So with rheumatoid arthritis, for instance, with MS, we're not quite there. But it remains a major topic of interest as far as understanding how that may play a role, and then how do we modify it, right? Because we had, something like a probiotic or a specific antibiotic that may help regulate the microbiome. That may just add another thing to our arsenal that was driving some reaction to either cause MS or to cause worsening. So definitely remains a topic of interest for us. Speaking of environmental factors, because there was a question about that. So the answers, I think, kind of go back to, what causes MS. I think it's a lot of things that cause MS. So genetic predisposition, but not any one gene. If we think about identical twins, if one gets MS, the risk for the other is about 30 to 40%. So it's not like a one gene, you get this sort of disease. If we think even in a family, so like I told you before, about 1 in 300 people in the US have MS, that vary slightly by different racial and ethnic groups. But if you are the daughter of a patient with MS, for instance, so then your risk of MS is certainly higher than 1 in 300, but it's actually still not high, in the grand scheme of things. So it's about 1 in 30. So certainly higher than 1 in 300, but also 29 out of 30 times, not going to get MS. So clearly not an enormous genetic issue there. Vitamin D has, a lot of people that have MS probably take vitamin D because we know that vitamin D deficiency is a risk factor. And we know in part 2 that there's an association with that with sunlight exposure and then different genetics and different populations, right? So places that have a lot of MS, so Norway, Sweden, Colorado, the UK, part of that's genetic, part of that is other environmental pieces. But there's not, I can't necessarily give, a risk score. I can't say you have these 6 things and we rank them and then this is your risk for MS. We're just not, really at that point yet. And then Epstein Barr, I think, is the big sort of, outstanding piece of the puzzle there. What else we got here? So question about diet. Does any impact or does diet impact MS positively or negatively? The answer is yes, positively, and I think in a few different ways. What I typically tell my patients about diet is certain diets are great, but if you don't want to follow the diet's not going to do anything but make you frustrated all the time. So you can find very restrictive diets that no one wants to eat that claim that they will cure MS or treat it. I don't follow any of that. when we think about all diet research, nutrition research in general is always difficult because a lot of it is self-reported and it's hard to get good controlled studies, in comparison to these sorts of drugs. What we see though come out time after time for things like heart disease, vascular disease, MS as the best diet, and also one that's reasonable to follow is the Mediterranean diet. So that's been associated with reduced symptom burden from MS, so most recently with fatigue, and then may have some association with reduced disease activity, although that's very challenging to prove. So on the surface, like Mediterranean diet is pretty simple, so sort of like the diet that people would eat in the Mediterranean, so like Spain, Italy, Greece, before like McDonald's came there. So like lean meats, limited fried foods, limited grains, but whole grains when possible, and lots of fruits and vegetables, and then some olive oil and nuts. So that usually is like pretty palatable, I think, for most people. I'm not a big believer in like these so-called anti-inflammatory diets or like the Walls protocol personally. I don't have a problem with it, like if that works for the patient. Like I'm not aware of any safety concerns with that. Really the only stuff from diet that we think a lot about is just if you're vegan or vegetarian, just to be careful about getting like vitamin B12 supplements, that sort of thing. And then soda, be careful with soda. Soda is challenging from not specifically for MS, but just for blood sugar control and weight gain, just because your body doesn't process soda super well because it's just sugar without any protein or fat or fiber. It's just not something our body's really used to having. So 5 minutes. Okay, and then we got a question about the inverse vaccine, so ANK700. So vaccines, a lot of times we're thinking about vaccines in the context of infections. So like we talked about a little bit with the impact of the medications, like historically when someone gets a vaccine, it's to basically to create a cell population that then is going to fight that infection. From an immune system standpoint with autoimmune diseases, you can think about, can we give you something that may reduce the inflammatory response? So that's where this, the so-called inverse vaccine is sort of trying to reduce the immune response to myelin. So myelin, again, being that nerve sheath lining that is at least one of the things that's damaged in MS. So the inverse vaccine is essentially giving like a protein that is part of that, and then having it targeted with a specific molecule so your body can sort of reduce inflammation against that target. That trial, it looks like that's safe. Theoretically, based on mouse models, it looks like it may be effective at reducing inflammation, but we don't have a lot of clinical data right now in humans as far as efficacy. But it's sort of the same idea as you can think about some of these things that introduce regulation of the immune system. It's a little bit more of an elegant approach than just killing all the immune cells. Where this may not be immunosuppressive, it may just help reduce a very specific type of inflammation that's really important. And unfortunately, that's also the Achilles heel for the inverse vaccine. Is if we pick the wrong target to reduce inflammation against, then it doesn't do much, right? So I think one of the challenges we've had historically with MS is it's very difficult for me to tell you like what should the target be, because we know so many different things are affected. Like I can't say that there's like a very specific like protein or something else that would be like, oh, that's the MS protein that the immune system is attacking. So on like for those of you who have heard of like neuromyelitis optica, for instance, which used to be thought of as like a severe variant of MS, but is actually a different disease. In neuromyelitis optica, the body is very specifically attacking one protein called aquaporin 4. So we did something like the inverse vaccine. We said, hey, don't attack aquaporin 4. That may be great for that disease. But for MS, there's probably like 100, if not more, different targets, and some may be more important than others. So not that the inverse vaccine won't work. It's just where we wonder is about how effective would it be just with one target. And I don't know. I think that's where the clinical trials would be very helpful for us. Because let's say like, 4 targets we could do that for, something like that, and those were most of what was important. And then the inverse vaccine is way safer than killing off part of the immune system, then great, absolutely, that would be a very attractive therapy for us. So we'll see. Check my list here. Yeah. So very good question. So, most MS patients are adults. So in the US, average age of diagnosis is about 30, 31. But certainly kids get MS, especially after puberty. Um, there are certainly studies for medications in MS. We are fortunate to have at Children's Hospital, actually 2 pediatric neuroimmunologists. So 2 people like me who just see kids, which is a very unusual to have that as a resource. I don't know that we're recruiting like right now for any like clinical trials for medications, but there are certainly several that are ongoing. As typically, we're always more cautious with kids, right? So we don't know as much about the pediatric immune system, as opposed to my immune system, which is probably pretty stable for the last 20 years. Like kids are still getting vaccines and still developing, so we worry a little bit. Not enough to not use effective drugs, but we worry a little bit. Like, let's say someone had MS when they were 10, and we just blast part of the immune system. We don't know exactly how that long-term safety compares to an adult, for instance. But there's a lot of studies, actively for Ocrevus, Gilenya has been approved, so fingolimod for pediatric MS, teriflunomide has been studied. So there's quite a bit. So for anyone that has any interest in specific research studies, or just like being on a list that we could reach out to you, we are fortunate to have one of the largest clinical research programs for MS, in the world, essentially. So we have dozens of studies at any time. Not just drug studies, but MRI studies, genetic studies, symptom management studies, rehab studies, all sorts of things that are available. So that information is definitely on the MS Center website, but also on our website at the university. You can just sign up and literally just be on a list that if someone sees something interesting, they can reach out to you about it. Was there anything on here that I missed that anyone wanted, or anything else anybody wanted to ask? Yeah. Yeah. I mean, it sounds like you certainly, without having every detail, it sounds like certainly at least radiologically isolated syndrome, which is like having MS on the MRI and maybe on the spinal fluid that looks like that, but not necessarily having the typical MS like clinical attacks. Pretty much in any case, that is a good thing, because if there's not symptoms, that means there's not as much damage, right? So that's where there's different philosophical differences. So I think if you talk to pretty much everyone at our center, for instance, including the pediatric doctors, pretty much all of us would offer treatment in that situation, because the risk of developing full-blown MS with clinical attacks, and if you have a brain lesions and you have all neuronal bands in a younger patient, is very high. We were to follow that patient off drug for several years, like that risk may approach like 70 to 80%. So in that case, it's like, well, why wait for the problem to, get worse before we start it, to treat it, right? So, not everyone probably feels that way. I think there's been a little bit of a change in the field as we've had clinical trials, like, proving that what we sort of already knew was true, but that drug would prevent patients from clinically getting worse, even in that situation. So yeah, I mean, just generally speaking, I think that that's very reasonable. Yeah. Yeah. So the good news about the high efficacy therapies, Tysabri is not on here, but Ocrevus, Briumvi, Rituximab, Kesimpta, to some extent Cladribine, and maybe Gilenya. The good news about those drugs is relapse rates are dramatically low, right? So we were to take all comers with MS, over time, like how many relapses, where people get symptoms, what they have per year, like maybe every year, every other year. If I look at like newly diagnosed patients who go on one of these drugs, essentially, if we take all the patients, not just the ones that are in like the drug trials, for instance, that rate can be as low as like 2%. So just from a more recent study in Sweden, so took brand new diagnosis of MS, regardless of severity, with relapsing disease, put half of them on rituximab. That rate of relapse over the study, so the annualized relapse rate was 0.02, so 1 in 50 patients. So especially if things go well for the first like 2 years, I would be very unlikely to have a relapse. Now, what these drugs are not perfect at is that either primary progressive or secondary progressive, where a minority of patients will have some slow worsening, over time, even if we shut off relapses and even if we don't have patients on MR. But that is a slow process. Certainly, we will have consideration of other options, should that be something that happens. But that is very slow. So we've got time to sort of figure that out. But absolutely, rituximab. Anybody else?
Mother with MS go for resources, particularly when you're newly diagnosed, can be extremely isolating so I just wanted to address that kind of from a nonprofit standpoint. The good news is, and we all kind of try and cover different things and provide different resources to people. We partner with the clinic at the University of Colorado. They do tons and tons of research, and so we are always trying to see how can we get that research out to you guys, particularly at our Ed Summits. We always do research presentations. We publish articles in our Informs magazine as well as our monthly newsletter. And then we have a wide variety of other educational programs as well. We have MS 101, which is a small group 2-hour session that goes over all the basics of MS, treatments, and wellness strategies. As far as emotional support, we have a licensed clinical social worker that we offer 2 free counseling support sessions with. She has extensive two free for anyone. If you live in one of our rural areas, that access is actually increased. But she has extensive experience with MS, so she's a fantastic resource. We also have free consultations with a lawyer who specializes in applying for SSDI. And then some other great organizations that offer support groups, additional education. To speak to a navigator, they can connect you. They have a wide database that they can look at. All of them have really great programs. Again, we try to all do different things so that we can get you guys covered. If you would like direct links to any of those folks or any more information on those, I'm going to mention a couple of other programs that I saw the top information for them. Progression independent of relapse activity. So again, that kind of what does progression look like if you're not having relapses, or what might be causing that progression, as well as Dr. Alvarez will be doing a research updates section. We have many resources published about the DISCO MS, the Discontinuing MS medications. We have Informs articles and webinars. So again, I can send those direct links. We have a lot of information about the Mediterranean diet. And then also the idea of pseudo relapses. We have a presentation and article on that I can send out. So my email address, education@mscenter.org. Again, happy to be a resource for everyone. And I just want to say thank you guys for coming tonight. Thank you for great questions. Thank you, Dr. Wolf, for your time. And I hope you guys have a good rest of your evening.